Lindsay-Hemenway syndrome, vestibular neuritis, followed by benign paroxysmal positional vertigo. From dizzinessdoctor.com. Thank you. Thank you for your interest in dizzinessdoctor.com. If you are a person suffering from symptoms such as dizziness, imbalance, unsteadiness, disequilibrium, vertigo, etc., then our goal is for you to bring those symptoms under control. If you are a healthcare provider trying to help your patients manage those kinds of symptoms more effectively, then our goal is for you to understand better how to diagnose and treat the underlying disorder. Disclaimer: this material is intended for educational purposes only and does not substitute evaluation by a qualified healthcare professional. Accessing this material is subject to the terms and conditions detailed at dizzinessdoctor.com. Purpose of this presentation. The problem. What is Lindsay-Hemenway syndrome and how would I know whether I have it? The solution. We will discuss the presentation of, testing for, and management of Lindsay-Hemenway syndrome. Overview. The term Lindsay-Hemenway syndrome refers to the sequential occurrence of two inner ear problems that cause disequilibrium, vestibular neuritis and benign paroxysmal positional vertigo. The physical examination in terms of eye movements and workup in terms of vestibular testing reveal findings compatible with each inner ear problem. Treatment is with appropriately targeted vestibular rehabilitation therapy. Lindsay and Hemenway. Dr. John Ralston Lindsay was a Canadian otolaryngologist who served as the head of otolaryngology at the University of Chicago from 1930 through 1966. Dr. William Garth Hemenway, also a Canadian, did residency in otolaryngology at the University of Chicago while Dr. Lindsay was head of that division. The syndrome. In 1956, Lindsay and Hemenway reported the cases of 7 patients, each of whom suffered the abrupt onset of severe disequilibrium that left them bedbound for days before improving, but was followed by briefer, milder bouts of positional vertigo. Their original hypothesis. Based on autopsy of a single patient, Lindsay and Hemenway postulated that this clinical presentation was the result of a vascular problem affecting the inner ear. Some investigators still embrace the idea that this is a vascular disease. However, most investigators have shifted away from Lindsay and Hemenway's original vascular hypothesis. Among other data, Weisbluth and colleagues note that patients with Lindsay-Hemenway syndrome do not, on average, exhibit greater vascular risk factors compared to others. Most investigators have instead shifted to the idea that Lindsay-Hemenway syndrome consists of a sequence of vestibular neuritis followed by benign paroxysmal positional vertigo. Each of these diagnoses is quite common and can occur independently of the other. However, the risk of getting benign paroxysmal positional vertigo is higher in a patient with a prior history of ear problems, such as vestibular neuritis. Clinical history. First phase. The clinical history is compatible with vestibular neuritis followed by benign paroxysmal positional vertigo. In the first phase, the symptoms resemble what one would expect with vestibular neuritis, namely, abrupt onset, usually severe disequilibrium that is constant and slowly diminishing over days to weeks. Clinical history. Second phase. The second phase can begin while the first phase is still active or after the first phase has resolved. In this phase, the symptoms resemble what one would expect for benign paroxysmal positional vertigo, namely, brief bursts lasting seconds to a couple of minutes of positionally triggered disequilibrium that often, but not always, has a spinning quality. Physical examination. For clinicians. If a patient is examined during the first phase, physical examination findings should be compatible with vestibular neuritis. Specifically, on ocular motor examination, on primary position of gaze, there will usually be spontaneous, unidirectional nystagmus that is predominantly horizontal, sometimes with a modest torsional component, that obeys Alexander's law, which is to say that it increases in frequency and amplitude when the patient shifts gaze in the direction of the fast phase of the spontaneous nystagmus, and it decreases in frequency and amplitude when the patient shifts gaze in the direction of the slow phase of the spontaneous nystagmus. If a patient is examined during the second phase, physical examination findings should be compatible with benign paroxysmal positional vertigo, involving some canal, usually the posterior canal, on the same side as the antecedent bout of vestibular neuritis. Workup. Workup in Lindsay-Hemenway syndrome will usually show evidence of vestibular weakness on the side affected by vestibular neuritis. Specifically, there is usually some combination of caloric weakness. Video head impulse testing will show low gain and compensatory saccades, and there is weakness on cervical vestibular evoked myogenic potentials and or ocular vestibular evoked myogenic potentials. Management. The management of Lindsay-Hemenway syndrome is the same as for each of its component diagnoses, namely, appropriately targeted vestibular rehabilitation therapy. If a patient is still experiencing some degree of chronic unsteadiness, likely from vestibular neuritis, or if their ocular motor examination still shows spontaneous nystagmus, then vestibular rehabilitation therapy will probably begin with exercises aimed at unilateral weakness, such as gaze stabilization exercises. If a patient only has evidence on examination for active benign paroxysmal positional vertigo, then vestibular rehabilitation therapy will probably include cannulate repositioning maneuvers targeting the affected canal. Prognosis. Chauci and colleagues longitudinally studied 98 patients, including 36 with Lindsay-Hemenway syndrome, 30 with isolated acute unilateral vestibulopathy, which is to say vestibular neuritis, and 32 with isolated posterior canal benign paroxysmal positional vertigo. They reported that patients with Lindsay-Hemenway syndrome experienced more severe vestibular dysfunction, slower recovery, and more persistent benign paroxysmal positional vertigo than isolated acute unilateral vestibulopathy or idiopathic posterior semicircular canal benign paroxysmal positional vertigo. Balatsouras and colleagues compared two groups. The first was 22 patients whose benign paroxysmal positional vertigo occurred within 12 weeks of vestibular neuritis, although they did not specifically designate such cases as Lindsay-Hemenway syndrome. The second group included 284 patients with idiopathic benign paroxysmal positional vertigo. They reported a higher rate of recurrence of benign paroxysmal positional vertigo in the first group, which is to say the group with the antecedent vestibular neuritis. Whether the poorer prognosis in Lindsay-Hemenway syndrome is simply the additive result of two separate pathologies, or whether the acute vestibular syndrome and benign paroxysmal positional vertigo are synergistic, is unclear. Review. In this class, we reviewed the basics of Lindsay-Hemenway syndrome, including Lindsay-Hemenway syndrome is likely a sequence of two problems, namely vestibular neuritis, followed by benign paroxysmal positional vertigo. Physical examination, in terms of eye movement findings, and workup, in terms of vestibular testing, are what one would expect to find with each diagnosis individually. Each component diagnosis can be treated with appropriately targeted vestibular rehabilitation therapy. Thank you. Thank you for viewing, reading, or listening to this material, and for your interest in dizzinessdoctor.com. We welcome your feedback and support. The highest compliment you can give us is to refer our educational materials to others who could benefit from them.